So before I jump in, I do receive funding to look at antibiotic quality improvement in nursing homes, both from ARC and the VA. I do consult for on a small level for a couple of companies. Zurich's develops a cutaneous antiseptic, and Deb Group develops a hand hygiene monitoring system. Neither of these should be part of my conversations today. So what I hope to get through is talk just very briefly about the extent and consequences of antibiotic use in skilled nursing facilities. You've already had a lot of this, so I won't spend too much time on that. Talk very briefly about the regulatory history in skilled nursing facilities. This audience is well aware of those, so again, you probably can teach me more about that than I can teach you about that. We'll talk about the new mega rule in some detail, and then really talk about what I think are things you're probably already doing that you can leverage to meet the new regulatory requirements, and then talk about some of the strategies or kind of throw me a rope approaches that you can be doing to kind of look outside your facility to get some assistance. And I think you guys are very fortunate to have the resources in the state that you have. You have a number of individuals and organizations that I think are very well positioned to help you achieve these regulatory requirements. Many states don't have access to the resources that I think you guys have here. Okay, so why do we worry about antibiotic use in SNFs? Well, we use a lot of antibiotics in SNFs. If you stay in a SNF for at least 6 months, you have about a 70% probability of getting one antibiotic exposure. We've done a number of longitudinal studies in Wisconsin facilities, and our data matches up very closely with what is published on national levels and international levels. And when we went in and looked at use, we found that there are definitely hyperutilization subgroups. About 20% of the residents account for about 60% of the antibiotic use in SNFs. And we found, our record for 1 year was 15 antibiotic courses in one resident. You can just think about what that's doing to that individual's microbiome. Now, the problem we have is when we go in and look at the quality of those antibiotic prescriptions, about half of them are either unnecessary or inappropriate. And what I mean by inappropriate is on the right. We tend to use a lot of broad spectrum antibiotics in this population, but most of the infections that we're treating in SNFs are the pus infections, pneumonia, UTI, skin and soft tissue infections. And the vast majority of those are treatable with narrow spectrum antibiotics in most situations. And so the broad spectrum nature of our prescribing doesn't really match up with the microbial spectrum that we're often treating. And then the other thing that we find is that we're treating these infections for far too long. So again, the pus infections, we've got a mountain of evidence now that less than a week worth of therapy is as good as longer course of therapy, and in many cases is better because it leads to fewer side effects, less promotion of resistance, lower risk of C. difficile. And so I think there's a lot of opportunities, even if we do nothing to move the needle on avoiding antibiotic use, to improve the overall quality by focusing on drug choice and drug duration. Now, all of this use has a lot of harms, and I think we've done a bad job in messaging from a public health perspective. We've kind of focused on resistance, this kind of population level consequence of antibiotic use. It's a little bit like global warming. People sit there and say, yeah, it's probably a big problem, but I'm gonna still kind of drive my ATV around and guzzle gas. And I think what we really need to be focusing on is the harms of antibiotic use at the individual resident level. And this is what we need to spend a lot more time messaging. Antibiotics are one of the most common drugs for adverse drug events in skilled nursing facilities. There's a number of studies now showing transfers to the emergency department for adverse drug events. Antibiotics are in the top 3 in every one of those studies. If you look at C. difficile, there was a really nice study done out in the Northeast, which looked at residents started on antibiotics for suspected UTI. The vast majority of them did not meet McGear or Loeb criteria, so they probably had asymptomatic bacteriuria. And what they were able to show is about 10% of those individuals went on to develop C. difficile in the 2 to 3 months after that antibiotic treatment course. So we're triggering these C. diff events with these unnecessary antibiotic use. And then the thing that is more difficult to kind of show is the promotion of resistance. Again, we talk about resistance at a population level, but I guarantee you, you can go into any one of your facilities and find 1 or 2 residents where if you just map up all their urine cultures over a 2-year period of time, you are going to see the effects of antibiotic prescribing. So whenever I see a resident who's got Candiduria, Pseudomonas, Enterococcus in their urine, I know that that individual has got a boatload of antibiotics in the past. Those organisms don't show up without a lot of antibiotic exposure. So that's what we're doing to our residents. And so again, those are cases that you can kind of show to your providers that these are the harms of antibiotic therapy. The fact that that resident now needs to be hospitalized for an intravenous course of antibiotics because of the resistance in their urine is directly a result of all that upstream historical use of antibiotic use in that individual. So this is unlike any other medication. So the harms that we see with other drugs accrue only at the individual level, but they also accrue at a population level in the nursing home. Really nice study by Nick Daneman up in Canada. And what they did in Ontario, they looked at all the nursing homes, stratified them into high-using facilities, low-using facilities, and medium-using facilities. And then they tracked those residents over a 2-year period, nearly 100,000 residents, and they were able to find a very small percentage, maybe not very small, about 20% of the residents never got an antibiotic. 75,000 of the residents got at least 1 antibiotic over the 2-year study period. But they were interested in asking the question, what was the risk to those who never got an antibiotic being in a high utilizing facility, low utilizing facility, medium utilizing facility? And what they found was residents who never got an antibiotic but were in a high using facility had a 25% higher rate of C. difficile, diarrhea, and other antibiotic related harms compared to residents who never got an antibiotic but were in a low utilizing facility. So by converting your facility from high to low utilizing, you're not only helping those residents who would otherwise have gotten an antibiotic, you're helping all those other residents who never got an antibiotic in the first place. And then I think what we're going to talk about today is obviously the regulatory issues, and this is a direct harm to the facility. And I guarantee you that at least in Wisconsin, we've been utilizing the inappropriate medication use FTAG for many years. And this has resulted in a number of survey deficiencies in facilities in Wisconsin. And if that isn't happening in this state with the new mega rule, I suspect that it will start to happen. And then finally, the population level. Again, the thing that I think we need to de-emphasize relative to these other things is these residents transition back and forth from the hospital all the time, and what we're doing is generating the regional spread of resistance. And so being kind of a good steward for your community is another message that we need to be talking about here. Okay, so obviously government and public health authorities are concerned. You got a very nice talk from the public health authority at the CDC this morning. This is going to be front and center for the CDC and for public health authorities. So this is not going away anytime soon. There's a national action plan to eliminate or reduce healthcare associated infections. And obviously the White House released this national action plan to combat antibiotic resistant organisms. And all of this public health advocacy was a direct result or led to the mega rule. The mega rule wouldn't have happened without this type of advocacy. So you can blame Arjun for the Megan rule. He's not here, so I can say that. This is a big deal. And I think it's freaked a lot of people out, appropriately so. But I also think that you guys are doing a lot of things already that you're not as bad off as you think you might be. So we're going to talk about that. So you guys already know this history. Skilled nursing facilities were originally designed for domiciliary care, not to deliver medical care. We've kind of done a complete 180 in skilled nursing facilities where we're now providing a lot of medical care. Pre-OBRA, 1987, there was a lot of concern about widespread abuse of residents. Again, probably overblown, and we've kind of done an overcorrection with the regulatory issues, in my opinion. We need to be a lot more collaborative than punitive, but that's the system we have now. If you look at kind of the regulatory history, infection control stewardship wasn't a major part of regulatory language for most of the post-OBRA period. But yet, when people went in, infection control has remained the number one or number two survey deficiency over, as long as I've been following this field. So it's an area that's of high interest to state surveyors. Again, fairly absent is antibiotic stewardship. In Wisconsin, our surveyors took liberty with the inappropriate medications, and this is data on the right showing that about 1/3 to 40% of the inappropriate medication F tags are for inappropriate antibiotic use. So our state has been penalizing nursing homes for overuse of antibiotics now for a number of years. So 2016 is when the mega rule was first released. A lot of it is being implemented in phases. The final phase is to be implemented this fall, which requires that all facilities have an infection preventionist with dedicated training beyond their terminal clinical degree. And all of you theoretically should have an antibiotic stewardship program in place, as that was required to be implemented last fall. So, like everything related to survey, the mega rule is just the tip of the iceberg. It's the interpretive guidance that kind of dictates things. So when the mega rule was released, there wasn't a lot of detail on what to do. So the interpretive guidance is really there to kind of help us piece out what do we actually need to be doing at a facility level. The thing to remember is that the interpretive guidance is modeled after the CDC Core Elements. So if you're not familiar with this document, please get a copy, keep it in your facility. It has a nice checklist. Salman and his group are doing assessments that are modeled on a lot of this, and so you're technically following the core elements if you're engaging with Salman's group in doing the assessments and the training. But this is a good document to be familiar with. It has a checklist associated with it. Again, you probably are already utilizing some modified form of a checklist already as a result of Salman's group's efforts. But this is a really nice way to kind of see, are we in line with regulatory language or not? So what are the specific elements detailed? So one, they want to see leadership support. They want to see that a facility has protocols and or policies in place that address each of those bulleted elements, and I'm going to go into some of those in detail. Now, the thing in this last bullet that I want you to pay attention to, this is not gotten as much attention as I think it needs to, but they want to see clear documentation of indication, drug, dose, and duration. If you can't show that in your documentation, you will get a survey citation, I guarantee you. So working with your providers, working with your staff to make sure that this part of documentation is clear in your records. And again, they don't say where it needs to be. It could be in the physician order, it could be in the nursing notes, it could be somewhere else. But this needs to be somewhere in the record. And if you don't have that, I guarantee you the surveys will hit you. Now, we published this article in JAMDA. It is a draft antibiotic stewardship policy. It goes line by line through the interpretive guidance. to kind of address those elements in the policy. If you don't have a stewardship policy, this is a great place to start. You can kind of plug and play with the document. It's also probably a good article to read to see if you already have a policy. Does my policy have all of these elements? This will be very useful during a survey if you've got a policy like this. Okay, so Yoda, he is where I go to all of my sage advice. We're kind of learning on the fly how to do stewardship in long-term care. I'll be perfectly honest. We've borrowed a lot of things from the hospital setting because there haven't been a lot of good studies done in long-term care facilities. So a lot of what we recommend kind of comes from best practice in hospitals. That being said, I think a lot of what we see in the core elements and the interpretive guidance, it's pretty common sense, just best practice. And so I don't think it's too far out there. So there must be a medical director who is upset with this slide. So unfortunately, this is the current state in most nursing homes. You've got the DON and the IP doing all the work. And again, I apologize to the pharmacists in the room. Pharmacy and the medical directors have not been very engaged in antibiotic stewardship in nursing homes. And many times the medical director can be your worst offender, and that's really problematic. So I think one of the first things you need to do is take stock of what are your leadership resources, both medical director-wise and pharmacy-wise in your facility, and see how can you leverage those individuals more effectively to support antibiotic stewardship. Most people are not sociopaths. Most of the people want to help, and what they need to hear is what do I need to do? So coming to your medical director and saying, it would be great if you could give an in-service to the nursing staff about when they should be thinking about ordering a urinalysis. They will be generally delighted to say, oh yeah, I can give a talk on that. The medical director is really useful for helping deal with problematic other prescribers in the facility. It's not a comfortable thing for them to do, but that's why they're there. And so asking them, to talk with a colleague who is really out of bounds is a start, but going to them and saying, Dr. So-and-so continues to use this drug that's unnecessarily broad. This patient gets C. diff 3 times a year. Giving them data and actionable recommendations to go back to their colleague will help them do their job more effectively. So lead them to the water, so to speak. I think for the pharmacist, again, a lot of this is driven by what's in your contract language for your facility. So when you're renegotiating your contract or you're talking with your administrator about how can we leverage our consultant pharmacy more effectively, thinking about trying to incorporate some of that into your contract language with your consultant pharmacy, I think is a very useful suggestion. And a lot of times those pharmacists want to help. And so again, figuring out what they can do to help in the facility for a limited amount of effort, take advantage of them. Don't feel like you need to carry the burden all on your own. So this is just data kind of summarizing what is visually projected on the left-hand side. I think when you look at, from a structural perspective, a lot of facilities don't have prescribing guidelines. I think that this can be a very useful tool to codify, when are we going to send a urine culture? How are we going to treat UTI? How are we going to treat pneumonia? That can kind of be a straw man argument, when a provider comes in and is, prescribing gazillicillin all the time, saying we don't treat UTIs in this facility with those broad spectrum antibiotics. And again, when I was talking over lunch, I think if there's one type of infection to kind of focus your efforts on initially, urinary tract infection is obviously the highest yield in my opinion. So how can the medical director help? I've already talked a little bit about this. I think role modeling is really important. And so if your medical director is your worst offender, politely drawing their attention to the fact that they're the worst offender, sometimes they don't know. Usually they know, but sometimes they don't. You want them engaged in your QAPI meetings, and you want them reviewing and developing policies and procedures. And again, I think a really useful tool is to get them engaged in doing staff education. And then I've already talked about helping them manage the negative deviance in your facility. Yep. So the antibiogram, and I asked this question at Dan's talk, I think can be very powerful. So knowing what your resistance rates are in your facility, particularly for certain high utilized classes of medications. So fluoroquinolones come to mind very rapidly. If 60% of your urine isolates are resistant to fluoroquinolones, that class of drugs should not be used empirically in the treatment of UTI in your facility. And so getting that data, showing it to your medical director and saying, would you be in agreement with saying we're not going to use fluoroquinolones first line, is, you know, there's effort to aggregate that data. Sometimes your labs can help you collect this information. And you'll be meeting a regulatory requirement by doing this, because the regs say you need to track antibiotic use and you need to track antibiotic related outcomes. And so if you can kind of show the surveyor when they come in, hey, you know, we look at the resistance rates of all of our urine cultures, and this is the fluoroquinolone resistance rate, the Bactrim rate, et cetera. In addition to your MRSA and C. diff rates, you've met that regulatory requirement to track an antibiotic related outcome. Again, this is something I talked about at lunch. I can't tell you how important nursing assessments and communication to providers is. This is where you want to invest a lot of resources and efforts, because it's not going to only help with stewardship, it's going to help with everything else you do in the nursing home. So getting a good, consistent, reliable SBAR process in place is really important. Talking with nursing staff, how they communicate to providers a change in condition. Are they sending unconscious messages? We really need to test and treat this resident, or I'm getting pressure from the wife or the daughter, and now I'm asking you to start an antibiotic, so I'm just kind of pushing the pressure downstream. We need to be cognizant of how we interact with one another, and putting some emphasis on this at the nursing staff level is really important. This is data from a Wisconsin facility showing how a engaged, enthusiastic medical director can drive practice change. In this facility, they started looking at their microbiology data because they had an MRSA outbreak. They recognized that they had a lot of issues with Enterococcus candida in their urine, and they're like, we are prescribing a lot of antibiotics, and we're creating this. So he sent out a Dear Doctor letter, that's what he called it, to all of his colleagues with the micro results and with suggestions for practice change, avoiding unnecessary antibiotics for change in condition, using more narrow spectrum antibiotics for UTI. And they dropped their antibiotic use by a third with just the Dear Doctor letters. They didn't do anything else except aggregate some micro data and send out a Dear Doctor letter. And so this was very powerful for this facility. How can the pharmacists help? Well, again, I think the pharmacists need to be engaged in the QAPI meeting, where prescribing data, culture results, infection rates are being reported. They clearly play a role in developing facility policy and procedures. So if you're looking for how to standardize the treatment of UTI, the pharmacist can be very helpful in saying these should be our first line drugs in our facility. This is how they should be dosed and adjust for renal function, et cetera, et cetera. They can also help put together pocket cards, things of that nature. So they can be extraordinarily helpful in developing some of these strategies. I think they can be very useful in some of the tracking and reporting. So again, one of the regulatory requirements is you need to be tracking some antibiotic use measure. So the pharmacist can help. Now, if you have electronic filling data and they have an IT or informaticist who can pull that data, that makes it really easy. But it's still pretty challenging to work with long-term care pharmacy data. That being said, if you don't have that type of resource, having kind of an antibiotic event card that the frontline staff fill in and submit to the IP, who can kind of aggregate that, because they're doing that anyways for their infection rates. So you're taking advantage of frontline staff to collect some of the data the IP is aggregating, or the pharmacist is aggregating it, and then that's being reviewed at some regular interval. If you're doing those things, tracking antibiotic use, tracking an antibiotic outcome, documenting, that the indication, drug dose duration, and that you're doing some education to staff and facilities, you have largely met the regulatory requirements for stewardship. Now, I would argue you don't want to stop there, but if you're doing those kind of 4 things, you've largely met the regulatory requirements. So, when we looked at our facilities in Wisconsin, the vast majority said they were tracking some type of outcome. I would argue that they weren't trending it, which is really important to see where you were last year to where I am now. They could tell me what they had in the last month, but they couldn't tell me whether they've been going down, staying the same, going up. So in addition to tracking it, you need to trend it. Visualization of your numbers is really useful, very powerful for people like medical directors and providers to see. A lot of times, the people who were looking at it were the IP and the DON. Medical director often didn't see this data in our facilities, so that's a crime. The medical director should always be seeing this data. So I've talked a little bit about this already. So they want to see use, they want to see outcomes. Arjun referred to the appropriateness piece, and again, that's still really difficult to do. But I think it can be very valuable if you can get there. So what do I mean by utilization versus appropriateness? Just pay attention to the top 2 bullets on the left, antibiotic start and days of therapy. I think those are going to be the most useful measures to you. The days of therapy I find to be the most useful measure, one, because it's similar to what's being tracked in hospitals. And at some point, if nursing homes start to engage more consistently with NHSN, getting comfortable and familiar with the days of therapy measure, I think will be valuable. The other advantage, it also gives you a sense of what your duration of prescribing is in your facility. Antibiotic starts give you no information on duration of therapy. So even if you don't move the needle at all in antibiotic starts, but you go from an average of 14 days of prescribing to 8 days of prescribing, your days of therapy will drop in a major way, but your antibiotic starts won't change at all. So if most of your improvement efforts are focused on duration of therapy, you probably don't want to be just using an antibiotic start measure, if that makes some sense. Now, appropriateness, again, really complicated. Most of you are already probably familiar with McGeer criteria or Loeb criteria, and a lot of times I see facilities reporting out the number of UTIs that were treated that met McGeer criteria and the number that didn't meet McGeer criteria. So you are already tracking appropriateness of antibiotic therapy if that's what you're doing in your facility. Now, if that's too complicated to do, and let's say again, you're looking at duration of therapy, then track the number of events that are more than 7 days versus those that are less than 7 days. And so you're trying to get that percentage that are less than 7 days up and the percentage that are more than 7 days down. If you have a particular drug that you know you have problems with, fluoroquinolones, the proportion or percentage of antibiotic starts that were quinolones is another appropriateness measure that you can be tracking in your facility. So again, I'm not going to sit here and tell you which measure you need to use. You need to use one, at least, according to the regs. But I would argue that you want to look at, what are my problem areas? What do I want to affect in a positive way? And make sure that you're designing your tracking measures around that. And make sure you're putting most of your effort around where you're going to be tracking or trying to make improvements. If those aren't aligned, it's going to be really difficult to say whether you're having an impact. So again, if most of your effort's going to be on duration of therapy, you want to be using a days of therapy measure, and you may want to look at that percentage of treatment courses greater than 7 days. So the other thing is leverage pharmacy. They may be able to help you track some of this data in a low intensity way, particularly if they can access electronic resources. And they might be able to help you figure out how to stratify your data or visualize your data in a more effective way. I've already talked about this idea. Use your frontline staff to do some of the initial primary data collection. So in the bad old days of hospital infection prevention, we used to have infection cards that the nurses would fill out whenever there was a healthcare associated infection. They would hand it to the ICP, and the ICP would aggregate the data. But the frontline staff were filling out the information on the event. There's some issues with that approach, but you could see how this could be scaled up more effectively. If your ICP is going around and spending most of his or her day tracking down data on infections, they can't go out there and do education and kind of reinforce best practice. And so helping them collect data, I think, would be very useful. And finding ways to integrate this into infection surveillance. So if your facility is already tracking UTIs, then just add on the antibiotic information into that surveillance activity. They're already in the record, they're already looking at this information, so just add it to their infection tracking form and figure out ways to turn that into a measure that you're reviewing in your QAPI meeting, reviewing with your medical director. If you don't have the ability to do this consistently on a monthly basis, then take a cross-sectional approach. Every 3 months, we're going to do a deep dive into specific aspects of prescribing. So for the next 2 weeks, we're going to look at every antibiotic use, and we're going to detail why they were started, what agent was started, what was the duration of therapy. You will learn a lot from just doing that, even if you're not doing it monthly. And again, you're meeting the regulatory language if you're doing that. They don't tell you how to do surveillance, okay? Again, I've already said, make sure you align your tracking with your quality improvement initiatives. Make sure you're trending your data. And then the other thing that I would say is be careful about comparing yourselves to external data, particularly if you don't know the methodology by which those data are developed. So benchmarking is a very powerful tool, but it only is useful if your apples are their apples. If you're comparing apples and oranges, you can kind of get led down the garden path. And then what I would say is education is still our most frequently used tool. It is specifically in the regulatory language. So you need to be doing some type of education to your nursing staff and your providers. You need to do both. Again, they don't say what, they don't say how much, but you need to have documentation that you've provided education to nursing staff and providers on that. And then I know that I'm running late here. The antibiogram is mentioned specifically in the interpretive guidance. They don't say you have to have an antibiogram, although a lot of facilities have interpreted that as saying they need to have an antibiogram. What they say is you need to be tracking an antibiotic use outcome An antibiogram is a way of doing that. They don't say you must use an antibiogram. So if getting an antibiogram is really challenging, I wouldn't lose too much sleep about this. If you're getting an antibiogram just to have an antibiogram, and you're getting the hospital's antibiogram, or you're getting a regional aggregate antibiogram, I will tell you that's not very useful. It's fine to throw up in front of a surveyor and say, I've got an antibiogram, but you really don't know anything about the resistance in your facility if it's the hospital's antibiogram or the region's antibiogram. You really need to know your facility's antibiogram. So if you can get that facility level data, very useful. But if it's really challenging, then I would pick some things and just say, you know, we're going to look at MRSA, C. diff, and fluoroquinolone resistance in our urine cultures. And now you've met the regulatory language, and it's actually useful to you, because now if you can go back to your providers and say, 60% of our urinary isolates are resistant to quinolones, we need to stop using quinolones, that's actionable information that you brought back to your providers. All right, I'm not going to spend any time on the external resources because you already have access to a lot of resources, and I suspect the other providers will talk about that. So I will stop there.